Okay, so welcome. My name's Katie Pryor. I'm the Education Manager at the Western New South Wales PHN, and we're really pleased you can join us tonight for a GP immunisation update. Before we get started, I would like to start the webinar by acknowledging the people of the Wiradjuri Nation, as tonight I'm sitting in Orange. But I also acknowledge the many different nations, clans, and traditional lands on which we all live and work. I pay respect to elders past, present, and emerging, and acknowledge their continuing connection to land, water, culture, and community. And I warmly welcome all Aboriginal and Torres Strait Islander Australians who are present tonight. Thank you so much for joining us. So thank you all so much for taking time out tonight for this webinar. We're always so grateful to Professor Nick Wood and the NCIRS for providing these annual updates to support all the wonderful work that you, our GPs, our pharmacists, and our health professionals all do in keeping our people and our communities immunised. A little bit of housekeeping before I pass over to Nick. This webinar is being recorded and can be made available after the fact to anyone who couldn't make it. As it is a webinar, everyone is on mute, but you can certainly use the Q&A button to enter any of your questions throughout the webinar, and we will try and get through as many as possible at the end of the presentation. This is also accredited for CPD points, so we will take your attendance. If you complete the evaluation at the end of the webinar, we can then upload those points for you. So tonight's presenter is Professor Nick Wood. He's a Staff Specialist General Paediatrician, Professor and Subdean of Postgraduate Research in the discipline of Child and Adolescent Health at the University of Sydney, and Associate Director at the National Centre for Immunisation Research and Surveillance. Nick holds an NHMRC Career Development Fellowship, leads the New South Wales Immunisation Specialist Service, and coordinates the Immunisation Adverse Events Clinic at the Children's Hospital at Westmead. Nick is interested in maternal and neonatal immunisation and research into vaccine safety and the genetics of adverse events. So with that, Nick, I'll now pass over to you for your presentation tonight. Thank you so much.
Great, thanks, Katie. I'll just share the screen. Hopefully you can see this okay.
Yep, that's perfect.
Great, thank you. And also like to acknowledge country, the traditional owners of the lands of which we're meeting today, and pay respect to elders past, present, and emerging leaders, and any Aboriginal and Torres Strait Islander people joining tonight. So it's my pleasure to give you an update on many topics in the next sort of 40 minutes or so, leaving some time for you to ask questions that we can either try and answer, or if not, get back to you with answer from the Brains Trust back at NCIRS. So COVID, flu, a little bit on what's new in the vaccines that are coming along, and a bit on vaccine safety. So where are we at with COVID? I suppose this sort of tries to tell a story of where we are. What you can see is that, you know, we throughout from January through this year, sort of fairly consistent rate. Slight increase in that purple line is the over 90s, and I think that's probably a reflection of coming into winter. The new variant, which I'll show in a minute, and the high testing rates in the over 90s, particularly in aged care settings. So where are we at with the variants? As you may have heard in the media, the XBB subvariants, which are recombinants of the BA2 sublineages, are the dominant strains now. This is what the media and others are calling the Arcturus variant. There's no change in the disease severity that we think for these subvariants compared to BA45, which was the sort of dominant one earlier. But yeah, so it's XBB, which is the main one now. In terms of risk factors for dying, what this is really showing you is that the hazard ratio goes up quite steeply beyond sort of mid 70s and certainly after 80. So So that's where that sort of in data influences the recommendations for booster doses, which I'll show you in a minute. And the other thing is that, which is you can see here, is the hazard ratio is also higher for people that have immune deficiencies, such as SCID, cancer or bone marrow problems. And that's the top part of that table. And then also those that have underlying, problems with, say, pulmonary hypertension, fibrosis, neurological issues. So that also influences the recommendation for who should get a booster dose. The other important thing to take into account is the evidence of natural infection, and we know, we know from years back about the levels because of the PCR testing that was being done, and then the rat test. But we also know that many people have a rat test and don't log it, so there probably is under notification. So the other way to get a handle on the burden is to do seroprevalence studies. And what this is showing is the grey, then the red, then the black, is the seroprevalence studies that have done at 3 different time points last year. And if we look at there is one that's about to come out, which is the 4th sero survey, but this has been taken from Red Cross blood donors, so people that turn up to donate blood, and we get a bit of extra blood from that time point across the country. And we do the sero prevalence study. We particularly look for COVID nucleocapsid antibodies. And what you can see here is that pretty much 18 to 50-year-olds on that serological studies, we're showing that 70 to 80% of them have had natural infection. A little bit less as you get older, but in that 18 to sort of even almost 60 years, it's somewhere between 60 to 80% of us have had natural infection. If we look at the children, this is data showing 0 to 19-year-olds. The blue dots are the nucleocapsid antibody, which also indicates natural infection. The red dots are spike antibody, and you can see in the 12 to sort of 20, 19-year-olds, the nearly 100%, and that's because the high coverage from vaccine in those age groups. But even in the sort of 1 to 11-year-olds, the nucleocapsid antibody is sort of 60 to 70%, again indicating very high levels of natural infection. So that, together with vaccine history, is what we're calling hybrid immunity. So Targi, in an algorithm, has tried to look at primary course series. This is primary course series for children. These algorithms are sort of fairly new. But what it does show is that the under 4-year-olds, if they've not got any risk factors, then there's no real benefit to having a primary dose. If they do have risk factors, then you can see either a 2-dose of Moderna or 3-dose of Pfizer. In the age 5 years and older, a 2-dose primary course. And then where we're at really now is the booster doses, particularly in the adult population. So under 5s, no booster dose recommended at this time. 65 years and older, a booster dose is recommended. And then in the middle 2 groups, the 5 years to the 64-year-old, what we do is we look at whether they have risk factors, yes or no. And you can see there, if you're 18 to 64 and you have risk factors, then you should get a booster dose, as long as it's 6 months since your last COVID infection. And again, if you're 18 to 64 without risk factors, or if you're 5 to 17 with risk factors, then a Targi's word is consider. And we'll talk a little bit more about what that word consider means. What we do know is vaccine effectiveness, and don't really need to look at the measles pertussis part of this slide, but more interested in the COVID part down the bottom. And what we're interested in vaccine effectiveness is protection against severe disease, and severe disease is usually defined as hospitalisation or dying. And you can see that the initial vaccine effectiveness for severe disease was around about 60%, and it was sustained by about 6 months. That was bumped up with a booster dose to the 80% mark, and then it sort of fell away, but it's still not falling away too bad. So it's at the 6-month mark, there's still 70-odd% effectiveness against severe disease, and that's really the main aim here. Against symptomatic disease, which is basically having some mild COVID, still being able to transmit the infection, the vaccine effectiveness is not as high. So So the take-home message from this slide is that a booster dose will boost your protectiveness against severe disease. So what does that word consider mean in the 18 to 64-year-old age group? And I suppose it really depends on what the people wanting to, what their reason for getting a vaccine is. And if they're wanting to stop themselves from going to hospital or dying, then the booster dose will give you, like I showed before, a bit of a modest increase in protection against that. If you don't want to get sick for wedding and travel plans, or you don't want to get symptomatic disease, in the context of hybrid immunity, the vaccine booster dose may not give you too much additional protection. And if you don't want to get sick and stop people, getting infected from you, again, the booster dose may not do too much, purely because the mRNA vaccines that we're using are not what we call sterilizing, so they don't really give you really good protection against infection. So that 65 cutoff is a little bit of a threshold cutoff. It's sort of, if you've got someone that's 64 with a couple of medical issues and it's been 12 months since their booster dose and they're about to travel to Europe, would a booster dose be useful? Yes, is probably the answer. But if you've got a 19-year-old who's had, 3 doses and natural infection and is pretty robust and fit, and it's only been 6 months since their last dose, then probably not a massive benefit from a booster dose from them, for them, and possibly a little bit of, you've got to trade off the risk of that booster dose with the very, the potential for myocarditis, pericarditis, which I'll talk a little bit about later on. This is a nice graphic, and the next graphic shows the bivalent vaccines, but this is the data on the original strain vaccines. And this is the bivalent vaccines. You can see that there's BA.4/5 and BA.1 bivalent. So what they mean by bivalent is they've actually got the original strain SARS-CoV-2 and mixed it in with the BA.1 variant. That's why it's a bivalent vaccine. The important part is that the bivalent BA.4/5s are approved for the age of 12 years and older. Okay. The BA.1s are only 18 years and older, and you can see that the Moderna one comes in a sort of suspension in a pre-filled syringe, so that's quite a useful administration benefit. But that 12 years and older is the approved age for BA.4/5. So people, we've had questions over the last sort of few months. What about healthcare workers? Should they get a booster? The line that we're using is that if you're 18 to 64 and you have medical comorbidities, then yes, you probably should get a booster dose. But if you don't, then you probably already had 4 doses as a healthcare worker. You've probably already had natural infection. And if you don't have medical risk factors, then there's not a massive benefit to having a booster dose. But if it's been more than 6 months and you want to do it, then you certainly can. Pregnancy, same recommendation really for the 18 to 64-year-olds. If they're pregnant and have underlying risk factors, then yes, it should be given to them. But if they're not, then again, it's sort of a risk-benefit decision. This is slightly different to what the WHO is recommending, where they are suggesting that pregnant women do get a booster in pregnancy. Can you have the COVID-19 vaccine at the same time as other vaccines? Yes, you can. You can have it with the flu. If they don't want to have flu and COVID at the same time right now, probably what I would do is try and get flu vaccine in first, because flu season is around right now, and then you can give the COVID vaccine, a week or so later. If you've had if you've had COVID infection, how long do you have to wait before you get the influenza vaccine? There's no real set time, but if you are recovered from your COVID, so you basically not got any fever and you're symptomatically, on the mend, then you can have an influenza vaccine. So we don't believe you have to wait a certain time before you can get the flu vaccine after having COVID. So summary for you and the kids. The easy ones are the under 5, so no booster in the under 5s. 5 to 11s, if they've had their primary course and they have risk factors, then you can give them a booster, but it has to be the original formulation. Okay. 12 to 17s, no risk factors, no booster. If they do have risk factors, then you can use the BA.4/5 probably. I would probably use that in preference to the BA.1 bivalent, as long as it's been 6 months since vaccine or infection. So that's all I was going to say about COVID. We can certainly have some discussion via the Q&A about that. In terms of flu, how did the Northern Hemisphere go? So you can see that, well, the first thing I suppose is the Northern Hemisphere flu season is opposite to ours. So it usually runs from October through to about February, over their winter. And they had a fairly good year just gone in the Northern Hemisphere. Mainly it was flu A, but no flu B, Yamagata. So that's the North American evidence. In Australia, this is the red line, shows the 2023 data. You can see that it sort of followed 2019 to begin with, and it might well, you know, if things pan out the way 2019, might sort of do the same sort of trajectory. Very different to what we saw in sort of 2020, 2020, I think 21, which is not shown there, but yeah, very different because of we don't have any of the much of the non-medical type interventions that we had employed for COVID, such as masks and physical distancing, etc. So yes, flu has commenced. 3/4 of the notifications so far are flu A, and about 1/4 is flu B. In New South Wales, you can see this is from the beginning of the year, flu notifications. You can see that the top two lines there refer to the 0 to 4s and the 5 to 16s. Interestingly, that sort of yellowy one that climbed fairly steeply from, you know, the last week of April is the 5 to 16s, and that just happens to coincide with school kids going back to school for the beginning of term 2. So yes, flu is certainly on the increase in the children, and you might be experiencing that in your rooms. One of the things we worry about is co-infections with flu and RSV circulating. How are we doing coverage-wise? Well, as you know, the vaccine is funded for the over 65s and for the 6 months to 5 years. We had a pretty good go at it in 2020 with, you know, well, we eventually got by this time 30% of 6 months to 5-year-olds having had the flu shot. And this year is very similar to 2022 and 2021. So not as much community interest in the 6 month to 5-year-olds. So only sitting about 10%, although it is a free vaccine. In the over 65s, it's a little bit better. We're already at the 45% mark for the flu, which is pretty good. Hopefully get that up to the 70-80% mark. How effective was the vaccine? Well, this is data from last year from FluCan. And, you know, people say, oh, it's not very effective. Well, you can say that based on last year's effectiveness, which was 50% effective against hospitalisation, we expect it to be similar. In fact, data from the North American experience just gone over our summer, their winter, suggested that it was about 50-60% effective against hospitalisation. So if we have the same strain circulating this year in our flu as compared to the Northern Hemisphere, we should see about a 50-60% reduction in hospitalisation. So that's better than nothing. These are the strains in the flu vaccine. There's every year now, there's a quadrivalent vaccine. So there's 2 A's and 2 B's. There's a new Sydney strain put in the flu A strain. You know a lot of this, but just to remind people that it is recommended for everyone over the age of 6 months. We usually have this debate about, oh, should I wait to get the flu vaccine to later on because protection only lasts 3 to 4 months and the flu season might not be till September. I think that sort of is out now because flu has arrived, and so time to vaccinate is pretty much now. It can be given with other vaccines, as I mentioned, such as COVID. and the other childhood vaccines. There's a note there about giving Fluad Quad and Shingrix in the over 65s. Hasn't been studied formally, and because Shingrix is a little bit of a reactogenic vaccine, it might be better to separate the administration by a few days. But if it's your only chance to get the vaccine in, then you can do that. But yeah, because they are reactogenic, Shingrix is better to separate it by a few days if possible. If someone did have the 2022 vaccine late last year, they should still get the 2023 vaccine now. So this is the funding. I won't go through it in detail. We can make these slides available. The list of chronic conditions is listed below. All Aboriginal and Torres Strait Islander people, and anyone over 65. In the white boxes are the vaccines that are funded under the National Immunisation Program. As you know, in the over 65s, they do require the adjuvanted vaccine, the Fluad Quad, just to get a better immune response. A few questions we often get asked, just to remind folk, if you've got latex allergy, can you have the flu vaccine? Yes. If you have anaphylaxis to egg, can you have the flu vaccine? Yes, and no need for any special precautions. We talked about the co-administration and the idea with Shingrix. We don't routinely recommend additional doses of flu, but if you were, say, a person that had the flu vaccine now, and then you were thinking that you wanted to improve your protection because you were travelling for a couple of months to the Northern Hemisphere early next year, then you can either have a booster here, or if you're able to access a Northern Hemisphere flu vaccine when you're over there, that might be a better bet. But you can, people certainly do that if they want to increase their protection. Safety data, encourage you to have a look at ausvacsafety.org.au. You'll see there real-time data from this year's flu vaccine safety coming in. As of just 10 days ago or so, we've nearly had 140,000 safety surveys completed, and the safety profile is looking pretty good. Those tabs on the right there will actually, if you click on those boxes on the Ausvac Safety website, you'll see safety data for those specific age groups. So just to comment on the 6 month to 5 year age group, nearly 3,000 surveys. This is safety data in the first week after the vaccine. And one of the things we always like to look at every year is the fever rate. You can see there that parents, 1 in 10 parents are reporting a bit of fever. That's in line with the flu vaccine that we see last few years at least. So we're not seeing any recurrence of the issue we had about a decade ago with the CSL flu vax story. So the fever rate is something that we watch pretty closely, and it seems to be at the moment in line with previous years. Other than that, other things like red sore arm, etc. Much less survey data from pregnant women, but nearly 1,000 pregnant women. And again, you can show them these are the sorts of effects that people are reporting. So that's a little bit on flu. In terms of RSV, just to sort of touch base to say that you know a lot about RSV, but I just wanted to highlight that there is some movement in this space, and next year when we come back to talk to you, there might well be some options available. These graphs here show you the burden of RSV, and what it is showing is that the top panel shows the 0 to 23 month ages, and if you look at the x-axis, you'll see that that goes up by thousands, and so the really highest rates are in that 0 to 6 month age group. The other panel down the bottom shows you the rate in the over 65s, and it's climbing quite steeply. This is data from up to 2015, so a little while ago now, but that's related to probably better testing when people got into hospital. So from the drug company's perspective, they're particularly interested in the young kids, and so there's been work doing maternal RSV vaccine and in the over 65s. And what's happened is that basically the range of pharmaceutical companies have developed RSV vaccines. and the US has just approved two RSV vaccines for use in people over the age of 60, and it's probably likely to hit, an application be made in Australia. We often follow the US a few months later, but I suspect there'll be a chance to try and bring the same vaccine into Australia. So a little bit on Japanese encephalitis. As many of you know, it's a mosquito-borne flavivirus, and it is out in this Western New South Wales region. Pigs are an important part of the supply in terms of amplifying transmission. So the mosquito bites the pig, injects some of the virus. The virus likes the environment, usually gets a larger burden. He gets bitten by the mosquito again, who then bites the human. And so that's how Japanese encephalitis is amplified by the pigs. We have never really had JE on our shores, except for the very tip of Australia in the Torres Strait and the Cape York. Unfortunately, due to climate change, La Nina, movement of the migratory birds and the mosquitoes, the Culex and Iliorostris, Japanese encephalitis has been detected south of the Queensland border, cases in New South Wales and Victoria, mainly along the Murray Valley area. But that has led to a program to vaccinate. The middle graph there shows the red local government areas for which there are concern about JEV, and as you know, this encompasses part of Western New South Wales, particularly out sort of Dubbo, Narromine, Trangie, and further to the west. So in response to that, the vaccine program has been launched. JE, the good news about JE is that the majority of infections are asymptomatic, and severe disease is quite rare, less than 1% of cases. But it can be very, very nasty. The encephalitis can lead to permanent disability and even death. But these are the common symptoms: headache, fever, muscle aches, back, neck stiffness, etc. There's a range of different testing that can be done to diagnose the JE. There's serological testing. There's often classic MRI findings. There's different CSF tests that can be done to look for the virus. But one of the key strategies to prevent it is obviously avoiding mosquito bites, and that's why the New South Wales Health program of Fight the Bite, but also a Japanese encephalitis vaccine. It's not currently part of the national immunisation program, but ATAGI does recommend vaccination for people in high-risk settings. So in New South Wales, in the box on the right there, you can see the LGAs. That's the local government areas where there is high JEV risk, and for which the vaccine is being made available. And there's a list there of the types of people who live in these LGAs and who either regularly spend time outdoors, homelessness, living in conditions without good mosquito protection, or engaged in flood recovery efforts. Free vaccines also available to anyone in New South Wales who works in a piggery or pork abattoir, or lab workers, etc. So what are the vaccines that are available? Well, there's Imagev and Gispect. The key differences are that Imagev is a live attenuated vaccine, whereas Gispect is inactivated. One of the benefits of Imagev is it's a single dose. Can be given from the age of 9 months. But as it's live attenuated, one of the concerns or the contraindications is that we can't give it to pregnant women and we can't give it to immunosuppressed people. Gispect, on the other hand, is a 2-dose schedule, and we've got more data there about the timing of different doses. But because it's inactivated, it can be given to pregnant women or immune suppressed. This is a slide which just tries to summarise the vaccine and the age. The take-home message really here is that Imagev over the age of 18, single dose, and hopefully at the moment no need for boosters. If you do get Imagev between 9 months to less than 18 years, then there is consideration to a booster dose 1 year or more after the primary dose if you have ongoing restricted exposure. And then you can see the recommendations for GESPECT and the different boosters there as well. We can give other vaccines if required, but certainly because Imagev is a live vaccine, we want to wait at least 4 weeks between different live vaccines. If you're going to give the vaccines at the same time, better to give them different arms. But I think GESPECT, fairly well tolerated vaccine, but if probably better to give it by itself rather than say with a flu vaccine. The common side effects from the vaccine include the usual things like injection site pain, redness, headache, fatigue, malaise. Children can also experience some fever, appetite loss, irritability, and more crying. We are doing a study down in the Murrumbidgee local health district in the Young and Cootamundra towns, and what we're doing here is comparing the subcutaneous Imagev with the intradermal Imagev. And the reason to do this is that if we were to get a big outbreak of Japanese encephalitis, say next spring, summer, when the mosquitoes get airborne again, and we had a supply issue constraint with vaccine, we could possibly shift to an intradermal route of administration, because the intradermal route is a 0.1 ml dose, and the subcutaneous route is a 0.5 ml dose. So for each vial of 0.5 ml, we could probably get around about 4 doses if we give it intradermally. So it just expands our ability to vaccinate with the current supply. What we don't know is how immunogenic and safe that particular intradermal route is. So that's what we're doing a trial right now, and got about just over 200 adults involved. I'm hoping to recruit some more. So just the other reminder, don't forget the routine. There have been, noticeable declines in vaccine coverage at a WHO global level because of the COVID pandemic. So what that means is that a fall in things like measles coverage, polio coverage really is going to impact the global ability to control those diseases, and it probably means that there might be spikes of measles internationally. Then what that means also is that we start to see cases being imported into Australia by travellers. So there have been, as shown here, I have that one there, measles. This is just 29th of March. There was a baby who was seen at Children's Hospital Westmead, an infant under the age of 1 and therefore not able to have the MMR vaccine, who actually acquired the disease whilst in India. So that just shows that measles can be brought in. Another case in Queensland. The other thing that we have seen is some polio cases internationally. And unfortunately, a lady died from tetanus in the North Coast. That's the first death from tetanus for a little while. So just a reminder, we don't want to have a decline in our coverage for routine vaccines. And just also reminded me to think about tetanus booster doses, that recent death of that lady. What we do know is that by about middle age, 1 in 5 Australians have low or undetectable levels of antitoxin antibody. This is boosted really nicely by a single dose of a tetanus-containing vaccine. And so if it's been more than 10 years and the person is sort of 50 years then or older, then consider a Boostrix or a tetanus-containing booster. Not funded, so not part of the NIP, but really quite important for travellers who might be overseas and have a tetanus-prone injury and be under-tetanused, if you like. and then having access issues to get either tetanus immunoglobulin or a tetanus vaccine. That's just a reminder about, don't forget the routine. And in the last sort of few minutes, we have, like all these things, a need to keep coming back to you because there have been some recent schedule changes. The first one is to say that the HPV vaccine is now a single dose and around about 12 to 13 years. That's the best timing because it's prior, hopefully and ideally prior to exposure to HPV. Vaccination is now, as I said, a single dose rather than the previous multiple doses. If, however, someone is immunocompromised, then they still need 3 doses of that vaccine. But the real change is moving now to a single HPV, which will be given as part of the high school program. Also a recommendation that men who have sex with men at any age should also get the vaccine. Depends on their age. But if they're, somewhere in that sort of 9 to 25-year-old age group, then a single dose. If they're over that age group, then they might need additional doses. Adults who are over the age of 26, not routinely recommended to receive the HPV vaccine. If they do it and they're over 26, then it's better the usual schedule is 3 doses. So that's the key change to HPV, a single dose. There is a new vaccine in town which is called Vaxelis. I'm not sure whether the pharmaceutical companies have been approaching you yet. It's a combination vaccine, as you can see there, with DTP, hepatitis B, IPV, which is polio, and Hib. So it's pretty much another comparator to Influenza Hexa. The key difference with Vaxelis, there's 2 key differences. One, it doesn't need to reconstitute, so you don't have that Hib pellet anymore, like you do with Influenza Hexa. And they're slightly using a different Hib antigen. So they're using what's called an outer membrane protein, which might well give slightly better Hib responses as well. So just 2 months ago, the PBAC assessed Vaxelis and it's been recommended for inclusion on the NIP. And the TAGI will probably supply a statement about how to use it, particularly how to use it in terms of someone that's already had, say, Influenza Hexa, and then you want to use Vaxelis. There was a trial which you can have a look at if you're interested, but published in PIDJ about 6 years ago now, where they actually compared Vaxelis with Influenza Hexa. And when they do these studies, what they're really trying to do is show non-inferiority in terms of safety responses, but also non-inferiority in terms of immune responses. So they have to measure antibodies to diphtheria, tetanus, pertussis, Hib, polio, etc. And in that, they've shown, as shown on the far right in this table, that the antibody responses were non-inferior. In fact, possibly even slightly better for the Hib component, but certainly non-inferior, and the safety profile was good as well. The other big change in the schedule is Shingrix is now going to be included on the NIP. It will be a 2-dose schedule, and it will be for people at the age of 70 for adults. For Aboriginal and Torres Strait Islander adults aged 50 years and above, and for adults over the 18 who are immune suppressed at high risk of zoster. Important to note that the catch-up for Zostavax actually finishes on the 31st of October. So, if you've got someone that's eligible for Zostavax now, Shingrix is not available just yet. They won't be able to access Zostavax after the 31st of October. Michelle Drulis, who's online at PHN, can help you identify patients who might be in that need to catch up that Zostavax. There's also some changes to the pneumococcal vaccines coming. There's a new 15-valent vaccine made by Merck Sharp and Dohme called Vaxneuvance, and Prevnar 20 is on the way. how these will fit is yet to be determined by ATAGI, and how they'll fit into the NIP, but it's under review. But what we can say is that Vaxneuvance is the 15-valent one. It's got those extra, compared to the 13-valent one, it's got that extra 22F and 33F components in it. The PBAC has looked at 15-valent one and recommended that it can go onto the schedule for non-Indigenous adults at 70 and above, for Indigenous adults at 50 and above, and anyone at increased risk of pneumococcal disease at 18 and above. So this is the line straight out of the handbook at the moment. And you can see that there is a mention of the 15-valent one. So at the age of 70, you can either use 13 or 15-valent. And probably what will happen is that might be amended to say a 13-valent or a 15-valent or a 20-valent can be given. But we're not just sure that, but that's probably the way it will go. The other things to say is that the handbook wording is slightly changing, which is not a big deal for you guys at the front line, but might make it a little bit easier. But what will be important and useful, hopefully, is a new COVID chapter in the handbook. At the moment, the COVID information is sort of all over the place in different places on the health.gov.au, but by having it in one chapter will hopefully make it much simpler, and that should be online soon. And then finally, just to sort of finish off a little bit on adverse events. As you know, you guys have a key role in reporting these. It's something that follows immunisation, but not necessarily as a causal relationship. So obviously a red sore arm, such as this one, is expected, not expected, but is a common known side effect. This is a large local reaction. And, you know, that probably should be reported given its size, but something that's the size of, say, a 20-cent coin don't necessarily need to report it. Certainly, if it goes beyond the joints, the elbow joint or the shoulder joint, then yes, definitely need to report it, because if you report that and the batch number, and then 10 other people also report that same thing, with the same batch number, then the TGA will say perhaps there's a problem here with that particular batch. So that's one of the reasons why reporting is quite important. Things like measles, like rashes after MMR, again, a common expected side effect, as it is a fever, so you don't necessarily need to report them. Australia has a pretty comprehensive safety surveillance system. We have the passive system, which you're all involved in reporting adverse events through to the public health unit and then on to the state health department and then the TGA. We have the active safety surveillance system, MOSVAC Safety. We have some hospital-based system like PEDS, which is scanning hospitals for adverse events. We have specialist clinics available, such as the NSWIS service and the adverse events clinic at the Children's Hospital. And we do now have a list of immunologists, stroke allergists who can see some adults who may have had reactions either via telehealth or in person if they need to. The linked data is an area where we need to work a bit more in Australia. Do this reporting, there's a national reporting form, send that through to your public health unit who can then put it onto the system. One of the things that we did see, which you're all aware of, was the myocarditis, pericarditis issues after the mRNA vaccines, dose 1 and 2, mainly affected the younger males after dose 2. That doesn't seem to be a problem so much with the booster doses. So, you know, booster 1, booster 2, we're not seeing an incremental risk with myocarditis with 3rd and 4th and 5th doses. Seems to be just for some reason higher risk with the 2nd dose. There is that link there to some guidance on how to manage it, which has recently been updated. But I think if you're all worried about myocarditis or pericarditis after an mRNA vaccine, then you know, that's where, particularly in a young male, the risk of an additional dose is outweighed by the benefits of the vaccine in protection. We have been following up these people that have had myo and pericarditis, and also following up people that have had the TTS, that's the thrombosis thrombocytopenia. And what we're doing in these particular follow-up studies is looking at their longer-term outcomes, the quality of life, looking at their cardiac outcomes, and we're actually collecting some biologic samples to do genetic testing, as well as for controls, so we can see if there's any gene that predicts why these people had these reactions compared to those that didn't. As you know, there is ENSLIST. There's the email down the bottom. We have a bunch of staff specialists and an immunisation fellow and a clinical nurse consultant who look at the emails every day. And we have a daily meeting where, as a group, we meet to discuss the answers to some of the more tricky questions, and then hopefully get you timely feedback. We found that this was probably a better system than the phone. It's fairly prompt service, but let me know if you're not getting a timely response, because I can try and help in that area. So just to finish off with some of the frequently asked questions. So this is someone who's over 65, could have had an adjuvanted flu vaccine, but actually didn't. They got just to say standard Vaxelis Tetra. Should you repeat that? Look, I think it's just considering the individual case. If they're a well 65-year-old, they're probably not much added benefit to repeating it with an adjuvanted vaccine. But if they're, say, immunosuppressed and may not have responded so well to that Vaxelis Tetra, then an adjuvanted vaccine might well boost their immunity. So there's no easy answer to that one. If the vaccine was given and it was 1 week after its expiry, how do you manage those circumstances? I think the easiest thing to do is to contact the public health unit. They can then advise you. In some cases, we'll actually have some evidence from the manufacturer to say, well, that expiry date has, recently been updated, and there is a bit of margin for, not being such an issue. So, the answer to that one is don't just check with the public health unit. Some of the other GPs around New South Wales are saying that Vaxero reps have been saying that you should get an additional dose at 2 years of age. That's what's in the product information, but it's not what's in the immunisation handbook. So if you start Vaxero, for example, Aboriginal baby, they get a 2-month dose, a 4-month dose, and a 12-month dose. That should be fine. But if you had someone at the age of 1 to 2 got their first dose of Vaxero, that should be fine as well. They don't really need a booster dose. And what's the preferred zoster vaccine? Well, I think we're in this stage where, Shingrix will be the preferred vaccine, to be honest. It really depends on supply and availability of that one. The issue with Shingrix is, one, it's good for immunocompetent and immunocompromised people, but it is a 2-dose course. But the availability of Zostavax will sort of wind down beyond the end of October. So that's it from me. I might stop sharing. What have we got, about 10 minutes or so for any questions? I think I could see one there.
Yeah. There's a couple in here, Nick.
Yeah, so there's one, since BA.4/5 are not circulating, is there any extra benefits from using the bivalent versus the original? Yeah, it's a good question. The companies, like you would expect to claim the market share, are now working on XBB variant vaccines. But I think the BA.4/5 is probably closer to the XBB than the original strain was. And certainly when we do head-to-head studies with an original strain booster and a bivalent Omicron booster, the antibodies that are produced by the bivalent do give you some neutralizing protection against the XBB variant. So the answer is, it is a little bit better than the original strain, but maybe when next time we come back, there'll be an XBB variant one. And then the other question is, if you had recently had pericarditis from non-COVID or vaccine, can you still get Pfizer? Yes, I think if you've just had sort of natural pericarditis and nothing to do with the vaccine, then you can and you've recovered from it, then you can have a booster dose. And it looks like there's a question from about the Shingrix. Yeah, so this will be an interesting one. The Shingrix was put on the schedule at the age of 70. So if you are 73 and you want Shingrix, then at the moment you have to pay for it. There's no catch up. If, however, you get Shingrix is available and you start the first dose before the age of 71, then the second dose should also be funded, if that makes sense, once you've turned 71. Another question: a 1-year-old child had a dose of flu vaccine at the end of 22 and second dose in February 23. So I'm not quite sure why she had 2 doses of the 2022 one. If she's a child with immune suppression, she probably still could have a 3rd dose. I'm not quite sure why she had so many of them though, but and if there were no side effects, she probably still could have a that I think perhaps what they did was, it was the first time she was getting the flu that she had the 2 doses. So that might have been what it was. Yeah. So yes, I think you could have the 2023 batch brand if there are no issues with the 2022 version. Any other questions or comments from anyone?
Looks like you've covered everything, Nick. We'll just give people a couple of minutes to type in any further questions. But no, look, it doesn't look like anything else is coming in there. So
we can make these slides available for the group if that's valuable as well.
Fantastic. Yep, that would be really wonderful, Nick, and we can send those around as a PDF to everybody, particularly all the further detail in the slides and the frequently asked questions are really, really helpful. So thank you so much for your time tonight. Really appreciate everything that you've shared with us. Thank you all for attending. I hope you have a lovely evening, and if you've got a moment, please scan the QR code to do the evaluation. We'll also send a link via email if you're having any trouble scanning that. And enjoy the rest of your evening, everyone, and we'll see you next time. Thank you all so much. One little comment there. Ken has snuck in. We can do that. Can you see that, Nick?
Yeah, it's a question about yellow fever and the booster doses. I don't know the answer, Ken, to be honest, to that one. I know that there was a recommendation that booster doses were no longer needed for that one, but maybe we can get back to you on that one. But yeah, yeah, not quite sure.
Yeah, we can take that on notice and send an answer around. Thanks, Ken, for that.
Great.
Wonderful. Right. Well, if there's no more last minute questions, have a lovely evening, everyone, and we will talk to you all really soon. Thank you so much.
Thanks very much. Thank you. Bye.
See you all. Bye.